thought we would start with a little bit about team dentistry. So we started up in January 2025, so we're quite a new service still. There is 3 of us in our team, so we're quite a small team compared to some that you'll see at other referrals, but I think that makes it so much better. The other person that I should have done, not so much person, the other person I should have put on here is actually Megan, who is on the floor at the front. She's our little mascot, team dentistry. So the team is obviously Hannah, who's at the front, scoffing pizza, living her best life. So Hannah is the head of our dentistry service here at Fitz. She has completed her EVDC residency at Eastcote Referrals. So she is a registrar and she will, fingers crossed, be sitting her exams in May, but we will see how that goes. Then there is me. So I am the designated dentistry RVN, but you will see me all over the hospital because I'm a jack of all trades. My primary experience is anaesthesia. It's kind of all I've done since the moment I was born, from the RVN womb to the moment to now. So all I've done is anaesthesia, and I love that. I've done a bit of ICU nursing as well and a bit of ECC here and there, but primarily all I do is anaesthesia. Apparently I live, breathe and teach it now, so that's really fun. So then we also have Lindsay. So Lindsay, I should probably point in case you didn't know who everyone was. So I'm the one at the top, and then we have Hannah here with Pablo. I think this is Pablo. This is my cat Tess. She's a funky anaesthetic, so she has a brain tumor and 3 legs, so she was really fun when she came into dentistry. And then we also have Lindsay. Lindsay's in the middle. So Lindsay is actually really cool. We're really blessed to have Lindsay on our team. So she is our dedicated dentistry PCA or VCA. She's also our RPS, so she's responsible for radiology as well with us in our team. And she is so cool because she is a human registered dentistry nurse, and she has got 22 years of experience. So she comes in here all guns blazing, knows everything. She's so knowledgeable. So this is us. So we're quite a small team, but as I say, we do our best to keep things going. Now, if anyone's eating and not so good with gross things, next picture's a bit gross. So I thought if I can get it to move. Thank you. So I thought I would break that awkward moment between introducing and starting with some nice pictures. So here we have got 3 patients that have come to see us. So firstly at the top is Aspen. So she's got a lateral luxation of her canine tooth. She did that by running into a bush and then she came out like this. So I can imagine that was quite terrifying for her family. Then we've got here at the bottom. So this pussycat has got a fractured mandible at the bottom there. And this is Claudia. And she's a nice girl. And then this pussycat at the top, I guess you can probably all work out what the problem there is that piece of mandible is not meant to be there. It's meant to be in the bottom of her mouth, yeah. So she's got a wonderful open fracture. So we're sort of basing it a little bit around what we would do with these guys if they presented to our referral. So it's me again, in case you didn't see a theme. So this is actually kind of funny because this is a neuro patient, not dentistry, but she was cute, so it's all fine. So first things first, obviously, is going to be triage and stabilisation. A lot of these facial trauma patients are going to present because they've been hit by a car, they've run into a bush and been hit by something, they've bitten down on a fence and then they've ripped away. We've had patients being kicked by deer. So we've had a little bit of everything. Hello, welcome. So we've had a bit of everything. So the first things first is going to be that moment when they present to the clinic and we're like, oh no, what do we do with this patient? So first things first, oxygenation and examination if it's safe to do so. So if the patient is a pussycat and they're dyspneic and they're panicking and they're stressful, maybe not the best time to TPR, but we definitely start with that oxygenation. If the patient will allow it, we want to do a full TPR, a full health assessment. So that would include a chest auscultation. That it's really important when we're listening to a patient's chest that we're not just like, oh yeah, okay, cool, got a heartbeat, it's all fine, there's no murmur. We want a full chest listen. You want to listen to all 4 quadrants of the chest. We want to ensure that we don't have maybe a pneumothorax, maybe a hemothorax, a diaphragmatic rupture we had recently in a pussycat, and that went unseen by the primary care and then was missed on initial presentation. And it was only when we CT'd and I was like, oh, there's a weird lump here. Turned out it was his intestines. So it's always important to make sure we're doing a full listen. We're doing a full abdominal palpation as well. So again, if tolerated, obviously they're sore and they're scared and they're stressed. So these things can be done in succession once the patient has started to calm down. Next thing would be blood work. So although not the most useful indicator for a trauma patient, if we're placing an IV and we can take that blood anyway, and we can just run it if cost allows, it is beneficial to make sure that we're not working with something underlying. We're not working with kidney disease, we're not working with liver disease, because that's going to make our treatment choices more narrow. So it's really important that if we can, we take those blood tests, but only if the patient allows it. Next stage, my favorite, an A-fast and a T-fast. Gold dust. We want to ultrasound the patient. We want to make sure that we are checking the chest, even if it is just a very quick little scan, just to rule out that there's not anything untoward going on. And then same with the abdomen. So we just want to make sure that organs are where they should be. We don't have a massive hemorrhage. We don't have something leaking where it shouldn't be, because obviously that's going to decide how we then go through the next stage of our treatment. And then my favorite thing, I'm going to talk a lot about analgesia in this presentation. I love, obviously, I'm an anaesthetic nurse in my heart. Well, actually dentistry, but anaesthesia is very important within that job role. So analgesia is so important. If the patient needs it, fluid therapy is going to be our next step, just getting them on some basic rate fluids whilst we figure out what we're going to do next. So there is that. So the next stage is going to be a basic neurological exam. So we're going to assess their mentation. Oh, can anyone work out what's wrong with the pussycat? Hey. So this patient was actually a couple of days post RTA. So for this cat probably is going to be her eyes for the rest of her life. Really sweet cat, and it didn't really bother her that much, but it was a really nice picture to demonstrate what I'm trying to point out in this in the next slide. So we want to look at mentation, we want to look at ambulation, we want to check our cranial nerves, we want to make sure that pussycat or our doggy friends, or even a bunny, whoever presents at your clinic, we want to make sure we're doing a full assessment of the neuro system. Quite often, not so much here, but in my previous role, when I did a bit more ICU care, you'd have these poor animals like show up from their vets, and they haven't even had a chance because they see the patient looking really rough, and they're like, right, straight to referral, which is fab. But taking 5 minutes to go, actually, is this patient safe to travel? Is there something I can do in the meantime? Can we provide some analgesia? Can we help this patient before they travel? Because obviously I understand that we want them in a referral where we can treat them like an ICU, something like this. So the key ones that I like are the ones that I've listed on the board. So the menace, the palpebral, looking at the pupil light response. We want to make sure that our eyes are moving as they should be. And then our vestibulo-ocular reflex as well. So we just want to make sure that as we're going through, that we have a working friend. That's the aim of the game here. So this is also something that we do observe gets missed a little bit, which is why I thought I would talk about it, because obviously nurses are the powerhouse of the veterinary clinic. So when that patient comes in, we had it really recently, and it was a really sad outcome for the patient, but where we hadn't noticed that there was abrasions to the cornea of the patient. So, and it was bilateral, and we tried to treat it, and actually we ended up losing one eye after doing a tertiary referral to Optivet, and then sadly the pussycat lost her other eye to the same thing. So cat ended up with like melting ulcers, didn't he? And it was a horrible outcome for the family. So not that it necessarily could have been avoided, but doing that before we lubricate the eyes, checking the eyes, making sure that we don't have aniosicoria that's maybe subtle, because it can be really subtle, and looking to make sure that we don't have any third eyelid protrusion, that we don't, I can never say this, so bear with me. Anna might have to say it. Anna, can you say it? Thank you, exophthalmos, can never say that word. That we don't have protrusion of the eyeball, that we don't have any corneal abrasion or ulceration. It's really common to see it. So it's actually really common. Most of our RTA patients will have some sort of corneal abrasion, and that obviously then requires treating to help ensure that that heals properly. And then if your clinic has it, we can also check the I can't talk today, I'm so sorry, it's going to be a day like this. Intraocular pressure. So we want to make sure that that eye is not going to rupture when we travel and stress the patient out even more. We want to make sure that those eyes stay in the head. That's important to me anyway. So just making sure that we are doing a basic ophthalmology exam as well. So the next kind of thing that I wanted to touch base on was fluids. And I know it's something we're all taught like in depth at school. And this pussycat is actually insane. So this pussycat had like a load of work done, and then 5 minutes later, this was 5 minutes post extubation. Pussycat was a bit spicy, so I extubated the patient in the kennel, and he just was like, yeah, I'm going to climb. And they were there to stop him climbing. They were there to reduce the amount of movement that the cat had within the kennel. Wasn't expecting the cat to jump up on top. So he made a joke out of me, but that's okay. So the first thing that when it comes to IV fluids, obviously we're taught, you know, get them on some Hartmans, whack them on twice maintenance, that would be great. But we can do better than that. So I understand that realistically, time pressure in clinic does not allow us to sit there, calculate losses and do all the maths, but actually we can make the maths really quick by just having charts available that allow us to do that. So we want to assess for shock firstly. Do we need to be administering shock rate fluids? Have we got a lack of blood? Are we hypovolemic? Yeah, sorry. Are we hypovolemic? Do we need to be administering more fluid than we're giving? Do we possibly need to be looking at blood products? Is this patient safe right now? So then we want to check hydration status. So we obviously have to remember that when a patient presents to us bleeding, that patient has been bleeding for an amount of time, and that could be undetermined. But we had a pussycat that got stuck in a wall for almost a week. So we don't know what losses happened in that patient. I mean, that patient was so crispy. Like, we don't know what losses have occurred in that patient prior to when they present to us. So we have to try and estimate that. And we can do that in a number of ways. So the main way that we would do that is using the AAHA guidelines, which do give us a really nice estimated percent dehydration based on things we can all check. So with fluid therapy, I suppose it's more of like an advocation for our patients that I am asking for in this situation. So going, rather than just whack them on twice maintenance, oh, is that enough? Is that too much? Can we calculate our losses? It's only going to be an estimate, but can we calculate that by checking our skin temps? Can we check how moist our membranes are, and just getting a number that we can then take from here, and we can move on to calculating what actual fluid rate our patients might need. The other thing that's also important to remember is that Hartmans is not our only option. It's very common for us to just whack them on Hartmans and be done with it. There are other fluids available. I'm not going to go into that. It's outside the depth of this kind of lecture, but this is more dentistry focused. I know it doesn't seem like it at the moment, but rather than just whacking on twice maintenance and cracking on with it like that, using our rehydration protocol. So it's written really nicely up here. So we would take our fluid I told you it's going to be that kind of day. Our fluid deficit, and working out, based with the body weight and the dehydration, how much we need to rehydrate that patient, and then work that out over a 12 to 24 hour period. We did it on a patient a few weeks ago, because you do try, but we have had a bit of a dry spell for facial trauma patients. And we did it, and we worked out actually twice maintenance just was not going to cut it. Like, it was going to take 2 or 3 days of twice maintenance in order for us to actually rehydrate that patient. So it is really important, I think, that we try and just do our best. And like we all do it, we'll just whack them on twice maintenance, but trying to be an advocate for following some guidelines. And it's all evidence-based, so it's always beneficial. So then my favorite topic, analgesia. We have so many options for analgesia now. It's so much fun. There's so many more studies coming out. It's a lot easier to have them access. I mean, does everybody have methadone in their clinics? Yeah, so I worked in one where I didn't have methadone, and I was just like, mind was blown. But that's great. So when we have a facial trauma patient, it's always important to bear in mind that this is going to be individual to the patient. And I know obviously none of, well, I don't think we've got any vets in here, or are we all nurses? We have a vet, woo, 2 vets, woo. We obviously as nurses don't have a lot of say over what the vet's plan is going to be, but we can have a discussion depending on the vet that you're working with. So ideally, when we have these patients present to us, I love a little giggle over there, we all know what that means. So when we have our patients present to us, ideally we want a full mu opioid given, right? These patients have just been, you're right, Meg? Meg has a vestibular thing, so she gets a bit distressed sometimes when she wakes up from a deep sleep. So ideally we want a full mu opioid. So ideally methadone, or if some clinics only have morphine, something that's going to really whack that pain and keep that patient comfortable whilst they travel over to a referral for their dentistry or their surgery. So remember that we can start with a low dose. You can start with, I mean, obviously I'm a nurse, I can't tell you what doses to give, but we can start low. If your practice usually uses a 0.2 of methadone and you're a bit worried that patient maybe is a bit flat, you're not sure, you can give a quarter. Pain score the patient in 20 minutes, give another quarter. Pain score, give another quarter. There are options for patients when we're worried about giving them pain relief. Obviously, I do say this with the asterisk that a lot of the time when we have a distressed cat, most of the time we will give something like butorphanol. and we wouldn't want to be giving a full mu opioid alongside butorphanol. So because it's obviously it's a no, I've had a brain's gone. It's a partial antagonist, so we don't want to be giving butorphanol and a full mu at the same time. So it depends on the patient and the situation, but I'm a massive fan of just whacking in a nice dose of methadone, keeping an eye on the patient, monitoring them, pain score, top up if needed. I have included a really nice example pain score of what we do in dentistry when we have these patients, and it does come up a lot because I love analgesia. Remember that any opioid will reduce tear production, so any patient, and I mean any patient that is on methadone or had a dose of methadone needs to be eye-lubed every 4 hours at a minimum. Obviously, if they're under anaesthesia, that is increased to Q30 minutes, but at the moment, the better studies, it's Q4. So if you've got a spay in that has methadone at 7 in the morning, doesn't go home till 4, we should be topping up eye lube in the middle. So we are seeing tear production far lower with patients that have had that, same with ketamine and a lot of these stronger medications that we work with. Next is our NSAIDs, and I say this with the full effort of my heart. If you've got a patient in hypovolemic shock, please don't give NSAIDs, okay? Because our kidneys are already struggling. And the only reason I say that is because we had that recently, that a patient was referred to us and they were like, yeah, we've given methadone. Oh, but the patient's in hypovolemic shock. And I was like, okay, brilliant. Okay. Equally, if it's all we've got, better than nothing, but it really cannot stress that it's just not safe in those kind of patients. But it is still a really good analgesic, and it is going to help our patients. So if we run those bloods and we know that the bloods are fine, our hematocrit is fine, our liver and kidneys, they're working perfectly, NSAIDs are an option. That's all I'm saying. So others we have are paracetamol, obviously dogs only. And we also have gabapentin, which I love, gives us a little bit of sedation, especially in our pussycats, but it works for dogs as well. And it's just that really nice kind of neuroleptic analgesic. So this is my gold star of analgesia. Hello. Next, we also have constant rate infusions. Out of everybody here, are you guys using constant rate infusions in your clinics? Or is it not really something we do? Yeah, sick. Exciting. That's okay if you don't. That's totally fine. It wasn't something I had ever seen apart from an MLK, so that's methadone, lidocaine, and ketamine. I'd only ever seen an MLK infusion in a primary care. I hadn't seen kind of constant rate infusions until I made it into referral or joint referral. So with constant rate infusions, we want to be careful that we're not overdosing or underdosing. Options for constant rate infusions, again, a little bit outside the breadth of the depth of this lecture, but I definitely wanted to mention it. So my favorite is ketamine. I also love a bit of fentanyl, not myself, but for my patients. And they are brilliant because they are max bearing as well. So they're going to lower the amount of anesthetic agents that our patient is requiring to stay asleep. And we do regularly utilize these for our dentistry patients, even the ones that aren't having facial trauma. We also want to tailor the doses to the levels of the patient's pain. So pain scoring is so vital. It's something none of us do enough. But by pain scoring our patients, obviously we can't ask them if they're sore, so we can only work to what we have. But just making sure we're trying to pain score our patients regularly, especially around when a dose is given. So if we have an inpatient, I like to try and visually pain score, even if I don't have to go in and touch. But I do like to visually pain score my patients, ideally an hour before when I give it and an hour after. But it's easy for me because I only have 2 patients a day. I appreciate that most of us have 7 or 8 patients a day, and it's not always possible to do that. But even if we're just pain scoring prior to giving the medication, we can be like, actually, this patient's really sore. I'm going to give the methadone, and then I'm going to come back in a bit and just make sure that that patient is less painful. And just going from there. So this was my example pain score plan. So this is literally what we do for our patients. So Dr. Hannah has prescribed this for multiple patients with team dentistry. So we love a bit of methadone. We do it Q4 here. We do it IV if we've got an IV. If not, then we can do it IM. So it ranges from 0.1 to 0.3 mg per kg, which most people go, oh, that's really high. But actually, it's a safe bracket for patients if they are sore. So if the patient's pain score is below 3, we would give a 0.1. If it's 3 to 6, we would give a 0.2. And if it's over 6, we would give a 0.3. If we're still seeing really high levels of pain in these patients, which we do regularly, then we would start to introduce a ketamine CRI. Ketamine is a drug that is in most primary care clinics, and it is something we can utilize in primary care. it's just always there as an option. And Hannah has very kindly put the dose that she would start at, which is 3. Ketamine's great because you can go all the way up to 10, but if you're doing that with a cat, you're going to have a very, very high cat. So just be mindful of our doses when we're doing it. But ketamine you can play around with. So if that is something that your primary care is open to trying, or you have a vet that's open to trying that, it's always great to have a conversation. So if the patient then consistently scores low, we can then drop down to buprenorphine 0.02 and then 0.01 and so forth until we're weaned off. Obviously, the aim of the game is to wean the patient off. If the patient is having buprenorphine and they start to score higher, then we have to have that conversation about pain again and readjust our analgesia plan. So obviously we've talked a bit about triage. So what are our key takeaways from what we've just discussed? The most important one is the patient stable? If not, how do we achieve that for this individual patient? Is that draining a chest? Is that giving more analgesia? Is that oxygen therapy? Is that doing something else? If we are patient, if we are stable, sorry, then is there any evidence of thoracic or abdominal compromise in that patient? Is there any evidence of a neurological deficit? And is there any ophthalmologic trauma? Now, the reason I've included these 3 questions at the bottom is obviously they are going to impact if your patient has one of these, what happens next? So if your patient has a neurological trauma and they're struggling in that sense, then obviously we want to be looking for somewhere that can help them there. So we'd be looking at our neuro referrals. If we've got something that's a bit more soft tissue, we'd want to be tailoring that care that way. So that's why these are included. But if they're all fine, we can investigate the facial trauma, which is why we're all here today. So we're about to have some really funny pictures of cats. So not funny, but funny. So this pussycat was absolutely doped up on pre-med. She was really high. This cat was lovely and comfortable, hence why third eyelids are here. So first things first, so we're going to talk a bit about the anesthesia now of how we would treat the patient once that patient has arrived with us. So first things first is we're going to give some sort of pre-med. We're going to combine a sedation with a full mu opioid, unless there is any concern that the patient is compromised in anything other than facial trauma. This is what we would go for. So personal favorites of mine are dexmedetomidine and medetomidine. I also do love a bit of midazolam, and I am very partial to methadone, in case you hadn't worked that out from my previous points. We also, for every patient that we have, we give them an antiemetic if they've not had it at the primary care. So we use meropetent. We do give every patient an antiemetic. The benefits of meropetent is it does have a very mild analgesic effect. It also helps when we are constantly moving our patients around. So obviously in dentistry, we don't just have a lovely bitch babe that's going to lay on her back from the moment she's clipped to the moment that she's recovered. We are going to be tossing and turning them. We've got to x-ray. We might have to move to CT. So we do like that because we want to reduce the chance that patient's going to regurge. So we do include an antiemetic for all of our patients. And again, my pet peeve from my days of locuming in primary care are when you turn up in a primary care and there's a drug sheet on the wall and it's like, if it's a 5 kilo cat, you give this. We should be tailoring our drugs to every patient. That's so important. A patient that's going to take 2 micrograms per kilogram of medetomidine to be sleepy enough to anesthetize is not going to be the same for the next patient. The next patient might take 7 or 8. So it's just really important that when we're assessing our patients, we're taking into consideration how painful they are, because they're going to need more sedation. We're taking into consideration how kind of energetic they are, how bright they are. There's loads of things that we all know when we look at a patient, we're like, you're definitely going to need more. And those are going to be those patients where actually sticking to a chart on the wall. I know obviously we're nurses and we can't override the vet in that way, but it is a conversation. So I think it's really important to consider that as well. So then induction. So I have mixed feelings on pre-oxygenation. I'm not going to lie. There are some interesting studies out there that show that once they've taken 2 to 3 breaths of room air, the pre-oxygenation is pointless. So if you have a patient who's in respiratory compromise, we want a tight-fitting mask over the face. No flow-by. Flow-by is pointless. We're only going to increase, if we're flow-bying from more than a couple of inches away from the nose, we're not actually increasing the oxygen that the patient is breathing, maybe by 3 to 4%. So we've taken it from 20 to 25, which really is not going to do that much. All we're doing is costing our practices money, but we feel better, and that's not really enough. So if we are pre-oxygenating our patients, we want to be using a tight-fitting mask. Obviously, we're talking about facial trauma. So in those patients, there are other options. I'm a fan of the nasal prongs. So you can have little nostril prongs that attach to an oxygen cylinder or to the main circuit, and that can provide your patient with some oxygen whilst you intubate. If we're not using a tight-fitting mask that's on the entire time until the moment that your surgeon is going to insert that tube or one of the nurses is going to intubate, there's a question as to how beneficial that pre-oxygenation actually is. I should have put the studies up. I did not, but they are interesting, so please have a Google. However, never don't do it just because I said that, because obviously your patients are the most important thing, not what I said. So if you're actually flow by is all we've got, we don't have masks, we don't have nasal prongs, I'm just going to whack the flow by right by their nose, but I'm going to get it really, really close. It's better than doing nothing. But if we're going for that gold standard, we want a nice fitting mask. That's been recorded. You can all rewatch that later and listen to that bit again. So we really want a nice tight fitted mask. Next is the Alfaxan versus propofol fight. We've all been having that our entire careers. They're very similar. I prefer Alfaxan for patients that are already tachycardic, because in my experience, I've noticed that heart rates tend to go up with Alfaxan and they tend to come down with propofol. So I try to tailor that, and I do prefer Alfaxan in cats. So really that's down to the surgeon's preference, but that's my personal preference. And then we want to give it slowly, really slow, really, really slow, so slow. And we want to wait and see what they do. We've all worked in a situation where they whack in a load of propofol and the dog goes mental. So we just want to make sure that we're trying to encourage our vets to give it slow. There was a really interesting study that they did where they looked at how much propofol was given when vets gave it to effect, when it was diluted versus when it was neat. And in the diluted one, it was some of the numbers that people were giving was so much less. You'd be so surprised. So we don't need as much as we do. It saves our practices money, and it's better for our patients because it's less work for their body to eradicate it. They don't need as much as we're giving. So just slow and wait for that effect. Intubation. I'm not going to bore you with how we do a normal intubation because I'm sure we've all done it. What I thought I would briefly touch on is some of the alternative methods for intubation that we can utilize, because I thought it was more interesting. So there's 3 different types of intubation. The bottom one is not very common. I've only ever seen it once, but I thought I would mention it because it is quite interesting, and it's not very well documented either, but I have seen someone do it. So I was like, I will include it. And I have added this wonderful side note that says, do not intubate the brain, because we're not trying to oxygen, well, we are, but that's not how it works. And we did have, there was a case report that was published about a vet who had managed to put an NG tube, but had managed to place it down the spinal cord. Yes, so the dog had a hole and managed to, in a facial trauma patient. So I did add this important note, okay? It's not just there to be funny, because I know I am really funny, but it's not just there to get a giggle. It does have a function. So my favorite is the first one. So this is a transmylohyoid intubation, and I'm really proud that I said that on the first try. So in this intubation, what the aim of the game is can anyone see what happened with this cat? Anyone see what we've done? Yeah, got a plate. So in that situation, Hannah needs full access to the mouth. I cannot provide her that if I've got a tube coming out of the mouth. I can't keep it safe. I can't extubate the patient. I can't do anything. So what we do is we actually come through under the mandible. So we come in, we want to avoid, essentially it's done basically the same as no tube, just with the trachea. It's quite cool. So what we want to do here is we want to make a hole at it's like medial, but parallel to the mandible. And then we kind of intubate through the mouth, down into the trachea, and then push it in and poke it down. And then we have a hole here in the mouth. So the tube is still coming out through the mouth, but the aim of the game is to kind of sit through the hyoid bone. So you can see here where we've come through. And then obviously this would be the skin. Yeah. So this is a really nice alternative intubation method that we can achieve realistically within a primary care clinic. So long as obviously you're competent and your vets are happy, because you wouldn't want to do it otherwise. Not you, but yeah, anyway. So, and you can see here where it's coming out of Pussycat's, the middle of her jaw. Yeah, quite a cool intubation. And then you would treat it like any other ET tube. The only thing you want to be careful of is the oh my God, what is it called? The balloon on the ET tube. Thanks. I told you this is going to be fun today. So we just want to be mindful of the cuff, because if we're moving the tube around, we want to make sure we're decuffing and then recuffing when it's in position. Okay. So you can either, well, how you do it is you would pull the end of the ET tube off, push it in, and then pull it out. No, you don't want to come through the hole. I mean, in theory, you could if you had an uncuffed tube, but because of the cuff, you wouldn't want to. No, so you would take the end of the ET tube off, and then you would decuff as you would normally, and then you would pull out through the mouth. So that would be, and then to close it, what we would do is we would pull the tube back out, so decuff, because we're moving a tube and we don't want to cause any spasm in our pissy cats. So we would take the end of our ET tube off, push it through the hole, back out the mouth, put the end of the ET tube back in, reattach to the system. Surgeon just puts a little suture in there, and then you can recover like normal. These are typically held in with like a Chinese finger trap suture. So very similar to your O tube, and it's quite a similar method to insert the tube as well. So then we have the nasotracheal. It's a cadaver, in case anyone was wondering. No, I'm kidding. What we would do here is we would place it very similarly to an NG or an NO tube. We would advance it down the nostril, and then we would pass it until we can see it at the back of the throat, and then usually it can just be guided down into the trachea. And we can supply oxygen and gases that way. Obviously, we probably wouldn't want to use a gas in this patient. We'd probably want to use something like a Tiva, because we just can't cuff it, because it's going to be a very narrow tube. This is not really achievable in anything that's not like a bull mastiff, because obviously the lumen of the tube is going to be tiny. So it's always worth bearing in mind that it is an option. I have seen patients like intubated in, not intubated as such, because it's more just nasal, but I've seen patients oxygenated like this in ICU, and then they would suture it to the nostril. So it is an option we have. And then finally, the good old tracheostomy. We all know about her, but it's still a valid option, especially if say you've got a patient that we need to do like a bilateral thing, and we don't really want to like mess around with doing a transmalar hyaloid. Tracheostomy is an option. We can do a temporary, or we can do a little bit more permanent if that patient needs that. We've never had to do this, but it is an option. I won't bore you all with how we place it, because most of us know, we are taught, but I thought I'd bring her up. Then we have a bit of anaesthetic monitoring. So out of everybody, just for my own personal nosiness, does everybody have a multi-parameter at their primary care? Oh, that makes me so happy. I've worked in primary care where we didn't have them, and it's just a nightmare. Obviously, we should never be using our monitor and not looking at our patient. Our patient is the most important part of the process, and still doing our audible checks with our stethoscopes, still feeling our pulses, because there's a lot of information that you, as a monitoring piece of equipment, is going to pick up a lot quicker than that multi-parameter will. So it's always important to remember to check your patient, but ideally for these patients, we'd want full monitoring. So we'd want a capnograph as our primary. I've kind of listed them in order of my most important. So capnograph is always my most important. It's always the first piece of equipment I will put on. It just tells us the most. Then we have the ECG. I just love an ECG. Pulse ox, blood pressure monitor. That can be an oscillometric, and it can be a Doppler, whatever your practice has. But either way, if we've all kind of got an oscillometric, crack on with that first. It's going to give you a reading a lot quicker. And then if we have it, airway gases. Not every clinic will have it. Not all of us are trained in it, and that's okay. If we have spirometry, it's just going to tell us a little bit more about how those lungs are functioning, and it's just going to give us that insight a little bit quicker. So I'm not going to drone on about that, but here we go. So this is the bit I really love. Okay, so like the considerations. What might we have wrong with our patient that we can fix and make better, but just as an anaesthetic nurse? This is all things that we can do and knowledge we can have as nurses that are going to make that massive impact to our patients. The most important one is these are RTA patients most of the time. Our facial trauma cats and dogs generally have had a run-in with a car and have lost. So the main thing that I'm always considerate with, yeah, I don't know now. The main thing I consider is lung contusions. Okay, so do we have chest trauma? The little ways that I can make that better for my patient is firstly, avoid ventilation. If we've got something in that lung that's leaking, giving IPPV, we're going to make it a lot worse and that patient's going to get a lot sicker a lot quicker. So if I have any concerns about the patient's chest, I will never do IPPV until I know. So that would be x-rays or CT. The next thing I would do with this kind of like situation is try to just raise the chest a little bit. The thought along that is to kind of try and reduce the abdominal pressure on the chest. If we've got a set of lungs that are already bruised, that are already hemorrhaging, that are already stressed, having that chest just slightly elevated is going to help us. The other thing, I haven't written it on here because not a lot of clinics will have it, but if you have access to medical air for your patients as well, to use for your anaesthetic machine, I would also be running an oxygen and air mix. So, and the reason for that is that medical grade oxygen does not contain any nitrogen, and nitrogen is fundamental for keeping alveoli open. So where we're lacking in nitrogen, we're losing alveoli no matter how hard we try. And then we have to start going down a complicated route of trying to reinflate them. And that can be really difficult. So if I have that option, some primary cares do, I did work in one that did, I would always run both at the same time and I would do a 50-50 mix. Just introducing that little bit of nitrogen into the respiratory system can help to keep those alveoli open. I'm always then really careful with fluid therapy. So it's very easy for us to overhydrate our patients and not realize. We've kind of all been in that situation where you're like, oh no, this, patient's struggling now. So we want to avoid overload. And the best way to do that is to make sure that we are calculating our hydration and making sure that we're going through that kind of the mathematics and calculating what we should be giving. That is something we can recheck your skin temperature, make sure that the patient is improving. And we can drop that fluid rate if needs be. So it's always beneficial just to keep rechecking. Avoid overload if possible. Be aware if the patient's got any cardiac, like pre-existing cardiac issues. That will help us to tailor how we're going to approach our fluid therapy. A lot of vets that I've worked in over the years will just whack them on 10 ml per kilo. That's very old hat now when they're anaesthetized. So we want to be dropping those rates to an appropriate fluid rate for our patients, because otherwise they're just going to wake up and they're going to be urinating everywhere. And we don't want that. So just making sure that we're mindful of the fluid rates we're using. And the other thing, if we've got any risk of intracranial pressure, we want to be having some sort of colloidal on hand. So that can be, most practices will have mannitol, and they're just going to save your bum in that situation where we're starting to see that Cushing's reflex. So that would be where we would start to see signs of irregular breathing. We'd start to see a bradycardia, a bit of changes to our blood pressure, and that's going to indicate to us that our intracranial pressure is increasing. And then in that case, we'd then want to start stepping in with things like mannitol. But there are other options, but it's the one we kind of commonly have. So then we also have positioning. So I did speak a bit about that. So the other consideration when it comes to positioning is, what does the surgeon need to do their job, and what do we need to keep the patient alive whilst they do their job? So that can look different. That's two different pictures, and that can be very conflicting. The surgeon wants them hung over the table. The surgeon wants them this way. So it's important to have a conversation before you anaesthetize the patient. For example, for us, it's in our pre-anaesthetic checklist. We discuss, where do you want the patient positioned? Which way round do you need them? Where are we operating? And we discuss that prior to the patient even having a pre-medication, so that we can decide about how that's going to work as a team, rather than it being, well, I want this, well, I want that, because that's not what's going to get us the best outcome. So we discuss it prior. We then also consider staging. So staging might be, that can look different depending on the patient, but sometimes it can be, okay, first anesthesia that we're going to do on this patient, we're just going to image and we're going to place a feeding tube. We're going to get a couple of days of nutrition into this patient, then we're going to move on. And we've done that before, where the patient presents, we do some imaging, say we run a CT, we place the feeding tube, and then we anaesthetize them the next day to then proceed with the surgery. They've had a bit of nutrition. We're starting on that nutritional journey, getting that patient back to solid. So then we can do this, the surgery. And then obviously if then we need to do dental extractions, which I will discuss in a bit later, when we do those, then we can actually do them again later down the line. So we don't have to do everything at once. We don't need to be having 10-hour anesthetics. We can stage things. I love this photo. This did rounds on social media a few years ago, and I am obsessed. It perfectly demonstrates my point. Thank you, Megan. Perfectly demonstrates my point as to why we need to take multiple views when we're doing chest x-rays. One lateral chest x-ray is not diagnostic, as demonstrated by old Harry. No, William, thanks. So William here is perfectly demonstrating a middle finger, but actually when we turn him around, he's actually holding up 3 fingers. So this is a perfect reason of why we do need 3 views, at least 3, or if you can only do, say the patient won't tolerate that, 1 lateral, 1 craniocaudal video, kind of however you want to take that chest x-ray. Obviously pussycats is probably going to be dorsiventral if they're struggling to breathe. So ideally a CT scan. Not every clinic has a CT scan. Some are moving that way now, so that's pretty cool. But if we don't, then we want to have at least 2 views, ideally 3 in a perfect world, chest x-rays. And that's going to tell us whether or not we're dealing with a pneumothorax, a hemothorax. It's going to tell us whether we've got lung contusions. It's going to give us a lot of information. Thank you for your assistance, William. Skull radio, oh yeah, sorry, I was just making sure I didn't miss anything. When we get skull radiographs, they are helpful, but they're not that helpful either. So if you've got a high-risk patient, it's not the best time to spend. So take the chest views. We can do more x-rays when they get to CT. We can CT the head, and that's perfect. It gives us everything we need. We can move it around. It's a 3D image. When we get one view of the chest, of the head, it doesn't necessarily demonstrate what we need to see. It may show a symphysial fracture of the mandible, but it could look really exaggerated. We had a cat recently where it looked really, really big, but actually when you moved it, it was very solid. And then we were like, is it even fractured? So we were expecting this really separated mandible, and it wasn't that separated at all. So do things in order of priority so that we get the best diagnostic imaging for that patient. And then one of my other favorite subjects, in case you hadn't worked out already, is local blocks. So I thought I would take you through the 3 kind of main ones that are going to allow a primary care or even just us, because these are the same ones we use, to block the lower, the upper, and both. So the first option we have is the inferior alveolar block. So this blocks the mandible. So with this block, we're basically feeling for the vascular notch in the jaw. We're feeling for the corner of the mandible. We go for the last molar, and then we want to draw a line from the vascular notch to the last molar, and then that's where we're aiming with our needle. We enter just behind, so the lingual side, just behind the molar, you can see here, so we're towards the tongue. We come in just behind that last molar, and that's where we insert our needle, and then we drive it towards and along the mandible. If you hit the mandible, it's not what we want. It's not going to harm the patient, but it's kind of not the aim. If we aim to up, so if we're coming towards the tongue too much, we can actually numb the tongue, which is not ideal for our patients, because then they wake up and their tongue isn't working, and that can be really distressing. This is a great block. We do it probably daily, and we really love it. It works most of the time. It's great. So then we have, the next option is the maxillary block. So obviously this is a cadaver. So with this block, what we do is the needle is inserted into the infraorbital foramen. So you can feel for it. Insert the needle there. Then we want to advance it down to the middle of the zygomatic arch. Hannah prefers to use a cannula to do this. So like an IV cannula, you would place it in, advance the hub of the cannula down into the foramen, and then administer the local agent there. The reason for that is that behind that hole is all of the nerves and nice vessels that power our face. So we don't want to be hitting them, because we don't want to cause more pain or hemorrhage. It does happen, but we want to avoid it. So with that, we can pass a cannula. That's not going to cause the damage that a needle might. So it's really important with this one that there is also 2 approaches you can do. So one is this one where you go through the little hole, and then the other one is to come from below the zygomatic arch. So you kind of come under and come up, and that's quite a nice, that's called the sub-zygomatic arch approach. And that's another way that we can do it without having to worry as much about where those vessels and nerves are sitting. Then the next one is the trigeminal. Now, this one is a little bit more anaesthetic-y. So I thought I would bring it up because I thought it was quite cool that it numbs actually both at the same time. So rather than just having one block to numb the top, one block to numb the bottom, it does both at the same time, because we're aiming with this one for where those nerves divide and split. So with this one, we would probably, if Ilaria, our anaesthetist, was going to do it, she'd probably use an ultrasound and a nerve stim, pop a nerve stim in the face, and it makes the whole face twitch. It's really gross. It feels really unsettling when you're doing anesthetic, like when you're monitoring the anesthetic, because you're like, oh, this should be happening. And then she would use the nerve stim, block, and then obviously wait for that trainer 4 to go. And then we can assess how the block is doing based on that. So with this one, what we would do is we would look for the gap. And I have actually pointed it out. So when Hannah tried to tell me how we do this, I was completely clueless. So we're looking for this gap between the jaws. Sometimes you have to open the jaw to find it. If you've got like a brachy or something like this, brachycephalic patient. So we're looking for this hole here between the mandible and the maxilla. And then we want to go in that hole and aim like kind of towards, it's like kind of towards the eye, isn't it, in a way? Yeah. And then we would be watching, it's ultrasound guided. So we look for the nerve and then we do that block. So it is quite cool. The trigeminal nerve is really useful. And then that would block the whole side of the face, because this point is where our mandibular nerve and our maxillary nerve split. We can get everything there. So for us, a priority is feeding. So when we do have our facial trauma patients, it's really important that they're eating. A lot of time cats come into clinic, we're like, the cats are probably not going to eat. That's not enough. So, and even with our dogs, a lot of time our facial trauma dogs don't want to eat either. So with these guys, what we want to do is prioritize putting a feeding tube in. That can be, as I say, staged. So we could do that first and then anesthetize them to do the surgery, or we can do it all at once. They're unlikely to have eaten since the trauma. They're not likely to eat during the initial recovery. And so that nutritional support is going to be crucial. It improves our ability to medicate those patients at home with the family. They can go home with these feeding tubes in situ, and we will regularly send them home until they're eating enough on their own that they're hitting their RER, and then we will pull the tube. So we prefer an esophageal over a nasogastric. It's safer to send home to the client. It's easier to use. They have larger lumens. All around, they're easier for us to manage. We do prefer those guys. And then I wanted to include a little bit of information, just like random little things that we really like to do. So clean away the dried blood. Cats hate to be dirty. It's going to really affect their mental health if they're covered in blood and they're caked in mud and all this crap. So what we want to do here is we want to clean away that blood, and we want them to be clean. We have a hairdryer and we will blow dry them while they're asleep to try and conserve heat. We tend to do it at the end. We'll clip away the hair from grazes and cuts. We want to make sure that they are as physically clean as possible. We want to clean the blood and the mucus away. I don't know if anyone noticed in the slide where I showed you those fractures, a lot of those patients had caked bloods on the hard palate. There was blood on the nostrils. There was discharge around the nose. Like, I wouldn't want to be like that. I don't want my patients to be like that. So we always do try to make sure we're cleaning them away. And if they've been hit by a car, 9 times out of 10, our cats are going to have grazed claws. Let's just clip those back. It's not benefiting the cat anymore. Let's just get rid of them. It's going to make them feel a lot more comfortable. So then I thought, you've turned up for a dentistry lecture, and I know I've not really talked much about dentistry. So I thought I would take you through a couple of the jaw fracture repair techniques that we utilize. So there are kind of like 4 main ones. So the first one is internal rigid fixation. So what this involves is a plate and screws. So the most important thing here, you can obviously see in this little guy, this one's really cool because I'm obviously a nerd for dentistry. So with this patient, and Hannah will correct me if I'm wrong, we can see here the carnassial tooth at the bottom. There is so much periodontal disease in this patient that it has eaten through the mandible and caused a fracture. Yeah, ew, it's gross. This is a Chihuahua. So they don't have a lot of bone anyway to play with. There's not a lot of bone to be eaten, but once it does get eaten, we get to this point, and then we have to start thinking about how we're going to fix that. So with this one, we removed the carnassial tooth, which obviously is our big molar, and then we put a plate and some screws. So quite cool. This is obviously a normally intubated patient. So that can look different. I obviously showed you the one at the beginning where we had the triangle shaped one that was secured to the top jaw as well. So it can come in different shapes and sizes, but obviously this was a really tiny plate. This is a really small patient. Important side note, we're obviously dentists. We're here for teeth. We do maxillofacial surgery as well, but we love teeth. And the aim of the game is to keep as many teeth as possible. That is what our job is. So when we're placing plates and screws, we want to make sure that we're avoiding the teeth at all costs. We want to be avoiding the roots, we want to be avoiding the crown, we just want to be avoiding the teeth. So we also ideally want to avoid the mandibular canal, which is obviously where like our blood vessels and our nerves run through the mandible. But sometimes we have to kind of sacrifice that. We make an assumption where there is a full fracture through the middle of the bone, that we've kind of already lost that sensation in that nerve. So we are okay to kind of place the screws there. But we have to make that sacrifice sometimes to get the plate on. But we don't want to be putting screws through teeth. Absolutely not. So then the next kind of option we have is our intraoral wire and acrylic splints. These are so fun to do. So this patient has got a symphysial fracture. Oh yeah. Bit gross. So what we've done here is we've used the premolars to secure the canines in place with wire. We've wrapped it around, we've twizzled it. I say we, Hannah has twizzled it. And then we've used a composite, which is a bit like acrylic, to hold that in. It's very similar to what we would use in human dentistry. In fact, it's probably the same. And then we cover that to give it strength. So we obviously need that jaw to support eating and biting, and hopefully not too much biting, but we've got to support the dog as they heal. So what we do here is we use the wire to give us the kind of integral base for our composite, and then we use the composite to go over the top. And what that does is it provides the strength to the fracture repair. Believe it or not, patients do really well with this, and they eat a lot better than I expected when I joined the dentistry team. I was like, there's no way they're going to eat, and then literally just woke up and ate, and I was really shocked. So this is a really nice option for our patients, and we do quite a lot of them. So then we have the next kind of option. So no, same option, but I thought I'd show you a pussycat. So this is that pussycat from the start with the complete open fracture here of the mandible. We've then used the premolars. Cats have less premolars than dogs. So here we have used the molars, and we've secured to the canines to keep that fracture in place. And then we've used the acrylic splint to go over the top. And that's going to hold that in place, and this cat did really well. So really exciting from what is initially a very horrific fracture. So then we have maxillomandibular fixation, aka the MMF. There are two different types of this. The first is a semi-rigid, and the second is the rigid. The semi-rigid is the one on the left. So, no, it's not, it's the one on the right. So with this one, what we do is we use composite. So a similar material to what we use with the splints. I like this one particularly because it's pink. Right, so we use composite. We use the composite to put these little metal kind of like slots in, and then we just use like endodontic rubbers, like elastics, to hold the jaw in place. And what we're doing here, the point of this is to stop, we use the canines against themselves to stop lateral movement of the fracture, because that lateral movement is going to prevent it healing. It's going to cause them to heal with a malocclusion where the teeth don't sit correctly. So preventing that left to right movement is really important. So what we're doing here is we're stopping the canines being able to come away from one another. So there's still, with the semi-rigid, there's a bit of movement. The cat can move her mouth, but she can't do left to right. And what we're going to do is the canines can't extend past the canine. So we're stopping that movement. And that's going to cause us to damage our fracture repair, our fracture as it repairs. So that's the point of this procedure. This is a hard one. So what we do here is very similar, but we use composite to bind the lower and upper canine. So this patient will have no movement of that jaw. Side note, cats absolutely loathe the rigid. They do absolutely fine with the semi-rigid, but the rigid they're like absolutely not. And this one did really well though, this specific patient. Yeah, she was a cool cat. She didn't care. So she did fine, but most cats won't tolerate a rigid fixation like this. So we prefer to do a semi-rigid with these guys. But dogs will tolerate this really well. And then obviously with these patients, it's really important that we keep them clean, because they are not able to clean themselves properly. They're not able to groom. They don't have that functionality. So that becomes our job until they're healed. Have I missed anything? These guys here will be exclusively tube fed if it's a rigid fixation. So we wouldn't even offer oral food with these patients. They would just be tube fed until the fixation comes off. And then we have the modified labial button technique. So this is really cool. Some of us have seen this in primary care. I definitely had seen these in primary care. So these are useful for when the jaw is broken. And what we do here is we take suture material, a very thick suture material, we pass it up through the jaw, up through the top, and we secure it with buttons. And that again helps to keep the fracture rigid and in place. The patient will have a limited range of motion in the mouth, but it won't be anything to write home about. But these are great. Plus you can get really cute buttons. And so they are usually tolerated quite well by families at home, because we have cute little wooden ones that match and we pick them out for the patient. So brings a little bit of positivity to what's not a very nice situation for our pussy cat. So these are quite nice. But it's basically just like one big sling. It's quite cool. And this one breaks my heart a little bit, but it is still an option. So the benefit of all of the other methods of repair that we've discussed is that we use the teeth against themselves. That's not an option in babies because they're going to lose those teeth and we lose that structure support. So with these guys, what we do is we put them in a muzzle. This is a really nice example of a taped muzzle that we've made, and we hold it. And what it does is it basically holds the jaw in place whilst the fracture heals. And then we go from there once the muzzle is off. They will spend their entire life like this for 2 weeks, 3 weeks. They heal really fast because they're babies, and I think it's really sad, but it is the best option that we have for fixing little teeth when they're gonna fall out. So this is a really, really young baby that had broken her jaw. So this is how we went about sorting that out. I do think it's a bit sad. And then the final option is just to simply not do anything. So not literally do nothing, but we let the fracture heal as it heals. There's going to be a malocclusion, meaning that the teeth aren't going to sit correctly. And then once the fracture is healed, we go in, we extract the teeth that need to come out. So with this pussy cat, we can see here that there is some malocclusion. So the canines aren't sitting where they should be, and neither of these teeth, they're touching. And what happens here is we'll end up with sores in the gums, we'll end up breaking down the teeth, and we can end up with reabsorption that way. So what we want to make sure is that we're going to come out, and I think when Hannah told me is we extracted these ones down here, and I think we extracted one of the canines as well. And what that meant was that the teeth are going to sit as good as they're going to, but this patient had a great outcome. So although it wasn't the most fancy of repair techniques, just to let it heal and then remove the teeth that need to come out, that is definitely an option. But the aim of the game with all of these is that we want to make sure that those patients have a perfect occlusion at the end. The teeth need to sit where they need to sit. We want to make sure they're sitting appropriately. We want to make sure that they're going to have functionality in the mouth and they're not going to be in pain. That is the kind of final option for the fracture repairs. So then we have the recovery considerations. So it's entirely possible patients that have these fractures are going to wake up and be like, what is wrong with my face? A lot of these patients don't have the ability to move the jaw. The movement is restricted. They are very likely going to panic. I'm sure we've all seen that episode of Grey's Anatomy where, I can't remember her name, but the main character, she has her jaw barred shut and she's like, got it, right? Our cats feel the same, but our dogs feel the same. They can't tell us that they're panicking. So these guys, if the patient is a candidate for it, I always like to sedate them before we wake them up. So that can look different for different patients. If the patient is quite poorly or compromised in a way, then obviously we can't, and we have to just kind of go with it. Those ones I would have a bit of induction agent on standby and a vet that will allow me to administer that if we need to. And then it could be an option of just re-intubate and try again once we've managed to recover the patient a bit slower. But primarily with these guys, we either want to be giving something like acepromazine like 30 to 40 minutes before the ISO is switched off. So the anaesthetist here likes 3 to 7 micrograms per kilo. So we're using really minute doses. I often don't notice that much of a difference in my anaesthetic when using these micro doses. But my personal favorite is a bit of dex/normal medetomidine. Really, really minute amounts, and just giving them like, I mean, we had a patient last week and we gave 0.25 of a microgram per kilo of medetomidine. That's a really small amount, but it was just enough to keep what we knew was going to be a very dysphoric recovery. It was just enough to prevent that from happening. The patient woke up, was a tiny bit vocal, and then settled straight down. And that's the aim of the game. We want to keep them nice and calm. We don't want them waking up and panicking and screaming and causing all that distress, because that's just not what we want. That's not our job. If the patient is going to be potentially dyspneic, say we've got chest contusion, say we've got something going on with the patient's lungs, we want to make sure that we have a re-intubation kit ready, or at least very quick access to it. I'm very fortunate that downstairs in prep here at Fitz, we have got everything that we need, and it's all right there, as well as like 20 other people. So if something is to happen, I have a big team of people that are going to be there. I will still make an intubation kit, and I will still have it in my patient's tray. I have it with me in case, because you never know when they might decide that they're going to go dyspneic and need to be re-induced. So always have that intubation kit ready, especially where we're doing surgery on the mouth. Just have it. It takes 10 seconds. You can ask a colleague to get it ready for you. Just have it, because it can make or break the situation if you don't. And then with the sedation, again, just have it ready and drawn up before you're going to wake them up. Discuss it prior to anaesthetising the patient. Can be part of your pre-anaesthetic checklist, your post-anaesthetic checklist, just having it all ready. And then I just thought I would pop through some of the things post-operatively. So I think I'm getting through a lot quicker than I thought, but that's okay. So post-operative wise, wound care, your patient is likely to have abrasions. They're likely to have little big wounds that might need a bit of love and support. So just making sure that we're clipping those up, we're cleaning them, we're keeping them clean in the recovery phase, just making sure that they're as nice as they can be for our patients. There's loads of options out there. Again, it's outside the scope of this lecture, but I thought I'd throw it in there for some consideration. So then we've got the support for our eyes. Did we note that they have got abrasions to the cornea? Have we noted that maybe there's some aniosicoria, eye lubrication? There's loads we can do to help those eyeballs. So just making sure that we're putting that as part of our plan for that patient as they go forward. It's always something we as nurses can bring up with our vets and just go, hey, have we thought about eye lubrication for this patient? Because actually we did notice that this patient has some abrasions to that cornea. Then secondary, tertiary referrals. So, you know, we've got the patient in, we've had a look at the fracture, we've gone, oh, actually, this is a bit much. Maybe we'll recover the patient and send on. And that's totally fine. We are here to fix them. That is our job as dentistry. That's what we do. So then there's also the option for us for tertiary referral. So as I said, unfortunately, the patient had a very sad outcome, but we did have the pussycat that had some really severe ulceration to the eye. It became a melting ulcer. It was outside of our remit, even with friends that are ophthalmologists. That patient did require a tertiary referral. And we will refer over to other services if we need to. There's no pride. We just want to get this patients back to square one where they are good. So referral is always an option for these guys. So then we've got fluid therapy. So with these guys, what we want to make sure is that we're regularly going back to our AAHA guidelines. We want to be coming back. We want to be reassessing. Often we just whack them on it. We're like, oh, cool, they're done. But that might not be enough. We might have ongoing losses that we're not accounting for. We just want to be coming back. And I love this because it is so quick to do this maths. It's not like we have to sit there and be like, oh, okay, how much urine have we got? How much blood have we lost? How much, like, we can base dehydration off of this. So if we don't have time to necessarily sit there and start weighing vomit, this is an option for us, is just look at our percentage dehydration. Obviously, if you have acute losses, then that's different. But it's just a nice option for just going that little bit further. So then there's also feeding tube management. So have an appropriate diet on hand. I know that the Royal Canin liquid diets have become gold dust in primary care. I know they're basically practically impossible to get hold of now. One of the things, so here we like the AD, and we mix that with water, and that's what we use for our feeding tubes. I personally find that does block up a lot of the smaller NG tubes if that's what your patient has. So when I was at my previous referral, one of the internal medicine nurses, she's a really cool nurse, she's a VTS in internal medicine, they worked out what the kind of best solution was, and they went with HA. So that is literally the dry food, soaked in water for like 2 hours, and then blended within an inch of its life. And that will pass through most tubes without blocking. It's not brilliant, but where we live in this medieval state of not being able to kind of get hold of certain things, we are able to use alternatives. So just do some research. Obviously, if you're going to start blending and like soaking foods, we want to know how many calories are in the dry that we're putting in, and we want to be mindful of how much liquid we're going to be putting into that patient, especially if it's a cat. You may find that actually the calories that we have to give, the amount of liquid, sorry, we have to give to achieve the calories is going to be substantial. So those patients, you're going to want to feed on a syringe driver, make it really slow. You can even drip feed them. So put them on a CRI and infuse them via their feeding tube throughout the day. It's always another option. Then we have these, which I actually really love, and I thought I would mention this as well. So we want to be aware of the lumen of the tube. So if we've got an esophageal tube, generally speaking, we're going to have a wider lumen. It's going to be easier to feed those patients. We want to go for the nicest lumen we can get with what we have for that patient. The other thing I wanted to add as a wee note is if we are going to be using feeding tubes to medicate our patients, we want to make sure that those medications can actually be crushed. I've had it before where medications that shouldn't be crushed are crushed, put down a feeding tube, and then the patient's not very well as a result. So with medications, is there an alternative that can be crushed and put down a tube? Is there a capsule alternative that's not a slow release? Is there another way we can go about achieving that medication for that patient? Is there IV alternatives? If we're sending them home and that's the only option we have, that's at the vet's that's the vet's decision. But is there other options that we have? Just being mindful that as nurses, we are the ones that are doing these feeding tubes, just making sure that the vets have been asked that question. Are you happy that we're going to crush that med and put it down that feeding tube? Because it says on the packet, do not crush. And that's our responsibility as nurses. The other thing is keep the entrance site clean. The amount of disgusting O tubes that I've seen over the years is feral. So with the feeding tubes, what they tend to do is they've got this feeding tube, we're drip feeding them this food, and then they regurgitate. And what does it do? It comes out the hole, but it's under a bandage and it's gross. So that is food, that is stomach contents, all there. We know they're more likely to regurgitate because there's a feeding tube in situ. So just twice a day, go right down to the bottom, put the bandage on. I've included this. Now, this is really cool. This is basically like an antibacterial disc that you can put against the patient's skin around the tube. It already has a hole in it. It's designed for that. You pop it around and then you bandage on top. And it just keeps an antiseptic surface right against the opening of that tube. I mean, it's not going to work miracles. Don't get me wrong. It's not better than changing it at all. But it's just an extra layer of defense for keeping that tube in situ. I put in basically what we do. So obviously, it depends how long your patient has been inappetent for. The patient we had that got stuck behind the wall for a week, that patient had not eaten for at least, I think we said 10 days. So with that patient, we introduced food so slowly. It was literally like 10%, and then 20, and then 30, and then 40 day by day. And then we had to step back. Having to step back is okay. Do not panic. If you're even having to step back, so say, for example, we start at 25, we get to 50 on day 2, we get to 75, we're like, yay, we're almost there. And then the patient starts to regurgitate. The patient's not tolerating that feed anymore. Step back, go back to 50%, sit there for a day, and then move forward. And again, I know it's not our decision as nurses, but it's definitely something we can converse about with our surgeons. So remember, the goal is getting to 100%. These patients should not be discharged until they are at least getting 100% RER via the tube feed. So you've got time. It's just really important that we can step back with these tube feeding situations. We've all had it, and that's okay. It's better to be feeding something than nothing, especially in these guys. So coming back to pain scoring and analgesia, because it's my favorite, as I said. So I've just re-put our pain score up there, so it's fresh in your mind. So just remember, we want to be pain scoring at minimum Q4. So every 4 hours at minimum, bare minimum, prior to when we're administering the pain relief. We want to know how much we should be giving. We shouldn't just be whacking in opioids. We've all done it. It's been a busy day. Oh, I don't have time. I'm just going to give you the methadone and I'll do it later. And then we don't do it later. We've all had weekends like that. So it's just really important with these patients that we want to be pain scoring with all of our patients, even our soft tissue patients, our spays, our castrates. Spays are a huge surgery. They're a huge abdominal surgery, and then we send them home like it's nothing. So just remembering that we have cut open a patient and we have taken something out. So it doesn't just apply to dentistry nursing in that regard. So just making sure we're pain scoring and adjusting our doses based on what the pain score says. I love it. Enough said. And then I had a final little note that I wanted to talk about, and that is checklists. I have brought them up a couple of times, and this is just personal for me because I love it. So checklists will keep you safe. And I've worked in practices before where there aren't safety checklists. We introduced a really cohesive dentistry checklist. There's checklists everywhere, but we are particularly passionate because there's a lot going on, and they do just prevent us from making mistakes. They increase the levels of patient safety. This is something that is well documented in literature. They prevent patient safety, They encourage patient safety, and they keep us safe as well as professionals. Like, we're all registered professionals and we're accountable for our actions. And we want to make sure that we're communicating. So Hannah and I will go, as I said before, we'll be like, oh, Hannah, what position do you want the patient in? And then that is jotted down. And then we know that when we come to putting that patient down, actually we have a quicker induction because we've already talked about it. It's not a conversation I have to have when I've got an intubated patient that I haven't connected to a circuit yet. It's less exposure to isoflurane. It's less exposure to airway gas. It's just safer for us. If you don't have them, please go away and have a look. Most places do now, which is fab, but I do love them. They also make the process consistent. So if you're like me and you love consistency, you like to know what you're doing today, it just helps to take some of the chaos out of the chaos of our professions. So I just thought I would give you a few examples of the ones we use. So in dentistry, we have a pre-anaesthetic. So that is prior to pre-medication. So that includes, right, Hannah's going to have to help here. So that includes things like checking the drugs. So double checking drugs, countersigning, although we do that within the nursing team. Hannah and I will physically look at the syringes we've got, and we will double check the volumes against what I've calculated. And Hannah will do that, and she tells me how much she has in the syringe, and I tell her how much I have written down. And we always do it in that order to prevent Hannah looking and going, oh yeah, that probably is about 0.7. It stops that from happening. So look at your syringe first, then check your paperwork. We also have, I've really run over, I'm sorry. We also have move to theatre ones, not so appropriate for dentistry, but we do have move to theatre. We have prior to recovery, and then we also have a post-op plan. Our post-op plan is a little bit different to everyone else's in the rest of the hospital, because obviously they have bladder plans and things like that. It's not always that relevant for Hannah and I when we're doing our dentistry patients, but it's still there. I'm really sorry I ran over. I thought I started later. And then I thought I put up some really cute pictures of patients. Does anyone have any questions for Hannah or I? Amazing. Well, then, all I have left to say is thank you very much for coming, and here's some more of our patients. They are all really cute. This cat was high as a kite, but literally the handsomest boy ever. And this is a whippet that got kicked in the face by a deer. Yes, so we have jumpers for our dentistry patients because obviously their faces are full of water, and they get very cold. So we do have little jumpers that we put our patients in, and they are washed by our team, and they stay with us, and they're fluffy on the inside, and they're really cute.